Welcome. We are not complete yet, or at least that's what the list said, that there would be some more participants. But anyways, it's 8 o'clock and we want to get going. So I'm just going to start all the recordings because we're recording this so we can put it online so you can watch it anytime in case you miss some of this while we start. So this is not like a webinar where I talk all the time. I hope so. I want to show some stuff. Of course, I don't want to present a PowerPoint. I don't have that. I just want to talk about what I do every day on an everyday basis, what I do in my practice with my patients, what I just did all day today, and what I teach, of course. This is what this is all about. So something not very well known yet, neurofunctional integration. A lot of things out there already, like neuroathletic training. It's been around a while. We've been around a while, but of course there has been some interruption in the past 2.5 years. So we want to get back on track, of course. So you can throw me some questions because you can be, if you want to be, you can be here with me to listen. Not only to listen, but also to hear me and talk to me and ask questions. So that's what I want to have. If you like to have that, we'll have some interaction. So let's just get going and let's just talk about what this whole thing is about. So neurofunctional integration, what is this about? So it's all about signaling, actually. It's signals coming from the environment, going into the brain, being processed, going into the body, and also, of course, signals from the body going into the brain, being processed and going outward, like me saying something right now, or going back inward, changing my state of physiology. And what we basically want to do is what we want to change the approach to the approach to the patient, because a lot of people still think that, well, neurological disorder is like something like ataxia or Parkinson's disease, and if you have a knee pain, it's like orthopedic, or you go to an osteopath and it's like more like a biomechanical aspect. And I say, well, it's all neurology. Everything you can encounter can be neurology. Of course, not everything is neurology, but everything can be neurology. So you have back pains, you have knee pains, you have digestive disorders, you have mood disorders, you have sleep problems. All these things can have a neurological component. And this is what we want to find out. So before I get into some of the details, let me just say something that's I think is very important. I read a study, this is a couple of years ago, like quite a few years ago. So this coming from medical school, I read a study. It said 50% of the people coming to a general practitioner have a functional problem. So I was wondering, okay, so I just came out of studying, I came out of university studying medicine. And we learned about structural problems, we learned about biochemical problems, all these things. And of course treatments, surgery, medication, all these things. What we didn't learn is about how to treat functional problems. So I was sitting there wondering, well, if there's 50% or up to 50% of the people having functional problems, I think it could be even more looking at the neurology of it. Well, how are we going to treat those? And for me, this is the reason why there's things around like acupuncture, which is a really fine thing to do if you know acupuncture. But I'm wondering, well, why do we need something like this that's like 2,000 years old with all these explanations that do not fit into our current medical understanding or physiological understanding? Why do we need that? Because in our medical system, we do not have a real good definition of functional medicine or treating functional disorders. So what's the system of function in the body? Of course, it's the nervous system. The nervous system is what regulates my movement right now when I'm moving around, when I'm talking. At the same time, it's regulating my blood pressure. At the same time, it's regulating my digestion. There's still some things from lunch in there. At the same time, it's maybe fighting off some germs that I acquired from my patients today, and so on and so on. So all these things have neurological components. So it would be very wise, from my point of view, and I'm doing that for 18 years, to look at the neurological component and to assess the nervous system and to treat the nervous system directly, not indirectly. So here's my thing. This is how I think about it. When now looking back, doing osteopathy, manual medicine, all these things I was doing. Well, actually, I was doing neurology. because I was touching, I was giving proprioceptive input, maybe proprioceptive feedback to the body. And how many times did I really manipulate something mechanically? Like if there is a tissue that has a structural problem, like after a surgery or after an injury, well, then you might really have to manipulate the tissue. But manipulation is more like a neurological manipulation. So chiropractors, Carrick Institute, they have been doing that for a long time, although they're still doing their adjustments. And I'm saying, well, I'm doing adjustments too, but they're very subtle. They're just information. It's just about the signaling in the system. Of course, this goes from the environment into the body, all the way down into the cell, and from the cell into the body and into the environment again. So it's an exchange of information. So what is this information all about? It's electricity. That's what it is. So of course, there's synapses that do transmit information through neurotransmitters, but of course, there's also synapses that transmit just electrically. So there's an estimation of about 50% of the synapses in the brain just being electric. So that's why I'm always saying I'm a body electrician. I'm doing electronics. So we have a term for people looking at cars nowadays. It's not a mechanic anymore. It's a mechatronic. So they're looking at the mechanics and they're looking at the electronics, and the first thing when I bring my car to the shop is he takes out his computer, plugs it in, and reads out the mistakes. So I'm saying, well, that's basically what I'm doing. I'm reading out mistakes in the system. So somebody coming in with back pain, I'm reading out the system of the vestibular system, the visual system, the somatomotor system, the proprioceptive system. I'm reading those out. So I'm giving them some input, seeing how the body reacts. And then the nice thing about this, and I think this is the really nice thing about it, it's not only an assessment, it can be a very detailed assessment, but treating it is very simple. And I want to give you an example of how simple treatment can be. So here you have your computer and here you have your printer. So I don't know anything about computers except for typing in some commands, but I cannot program a computer. Here's a printer. I'm not a mechanic. I don't know. I basically know how these things works, but so one time my printer broke down in my practice. So I called my guy, and what did he say? First thing he said is, well, just unplug the cable, the connecting cable, and plug it back in, the USB cable. So I did that, and there goes, my printer works again. And this is exactly what I think we're doing here. We can't get into details of function in the muscle because it's so complicated, all those proteins and the channels, the calcium channels, all those things happening. What we're basically doing is we're reconnecting the system. So we're just unplugging, or we're testing the wire, and then we're plugging it back in. So some people say we're resetting it. I want to say, well, we're integrating them. So we can have an integrated function. So what I want to walk you through here in the beginning is just a few steps of, or just a few ideas. And then I have my son, he's around here, and I'm going to have him come in here, and I'm just going to show how this works practically, because it's quite easy. It's really easy in terms of the treatment. The harder part is asking the right questions. So there's a lot of systems, a lot of nerves in the nervous system, a lot of brain areas that you kind of have to know what function they have and what they do. So you have to have a pretty good idea about the function of the nervous system and the anatomy of the nervous system to work with it. And I have, I think, a good idea after 18 years. I don't want to say I'm really into the detail, because you can't be. You can write a book of about maybe 500 pages or 1,000 pages just about the prefrontal cortex, about all the connections, all the issues in the neurons and the synapses and all the proteins that are there. So we can't get into this detail. We have to kind of take a broad view, but you can do things with that. You can do things with that. A lot of things can be done with that. Okay? So let me just walk you through some basic ideas. So I want to give you the opportunity to join us here in the discussion if you want to, or you can just stay there and listen to me. That's also perfectly fine with me. So here we go. So let's start with the brain, of course, and that's what we want to do. We want to treat the brain, and we want to treat the nervous system. And there's I want to say 3 aspects that we want to consider from a neurological standpoint. So we have the brain. So I'm just going to try to draw a brain. Not very nice, my brain, I know, but doesn't matter. And here's the spinal cord. So that's the central nervous system. Of course, we have the cerebellum here. So a lot of people, they will not come into your practice and say, well, can you just check my right cerebellum because I think it's off because my knee's hurting when I run. They're coming into the practice saying, I have a knee pain when I run. So my job is to find out if it could be related to the function of the cerebellum and treat the cerebellum or the connection between the cerebellum and the periphery. So let's just assume somebody has a knee pain. So there's a nerve coming off here, the spinal cord down here, and maybe there, over there is his knee. So he's got some bones here, and he's got muscle tissue here, and of course he's got ligaments and all those things. And all these things are signaling, receiving signals from the brain and signaling back to the brain. So it's a two-way street. So it's signals coming from the brain, signals going to the brain. Okay? So this is, and this will go in here, and then it's maybe switched around. It depends on what line it is, and could go in here, and could go to the cerebellum, and then could go to the thalamus, and then maybe could go to the motor cortex or whatever that is. Okay? So this is what we want to understand. This is what we understand. Somebody's coming in with a problem, with a movement problem, and he might not even recognize the movement problem or have an awareness for the movement problem. He might just be experiencing pain. So that could be his symptom, of course. Then it's our job to find out which part is going wrong. So, of course, if he fell on his knee, you want to check, you might want to have an x-ray or an MRI to see if there's a functional problem in the knee or a structural problem in the knee. He could have a small fracture in his tibia plateau or something like that. So, of course, that has to be checked. But if he just says, well, one day I woke up and I started jogging like every day and I had knee pain, well, it can't be really something going on in his knee. So, where is the problem? So we have two basic issues we want to think about. The one thing is the information flowing from the brain to the brain and so on. So this is not correct what I drew here. It's just a matter of illustrating what we're talking about. So this could be an information problem. I always say that's like the electric problem, okay? So that's one thing. And then I would like to know, like, which part is it? Is it this part going from the knee to the spinal cord? Or is it maybe this part because we have wires going all the way up to the brainstem? Or we have wires coming from the cortex going downwards all the way to the spinal cord and going to here. So I want to know if it's like in this part or if it's in this part. So I'm the electrician and I want to measure. So I want to do tests that I could maybe, and I'm saying maybe because it's not always very clear where the problem is. But that's how I want to go about it, and I want to be as clear as possible. But in the end, sometimes you can just make an assumption, saying, well, it's probably the part between the spinal cord and maybe the cerebellum. Okay, so this is the information system. So there is information flowing, and of course, this information, if this is something coming from the outside, like a target, like I want to pick up the pen and I want to draw with it, I have to see the pen. So motion always starts with the visual system. So here's something I want you to do. I want to take that away from this evening. If you have a patient in your practice tomorrow, and he might have neck pain or back pain, or hip pain or something like that. So more in the center. And he shows you, like you're asking him, well, what kind of movement hurts? So he's saying like, well, when I go like this, it kind of hurts, okay? So what I want you to do is to check if there is a neurological problem with the visual system. Just let the patient close his eyes. So then let him do the exact same movement again. So if the patient says it's better or maybe even the pain is gone, it's very likely, or it's most likely, that he has a problem with his visual system. Okay, because that's one thing in neurology, kind of looking at the whole thing all the time. So what's happening? Okay, I'm changing my weight. I'm going from one foot to the other. I'm not only moving my back. I'm changing my body position. I'm activating my vestibular system and also activating my visual system, because all of a sudden now when I move back and forth, the room is moving in front of my eyes. So everything is kind of like moving back and forth, and my brain has to be able to cope with that. So that's a really easy test. You can just do like this. Okay, patient comes in, say, well, side bending of my lower back hurts. Close your eyes. Okay, it's much better. It's not like 5% better. It's like 50% better. Could be only 30% better, sometimes even 80% better, or it's gone. Then you know at that point, oh, okay, that person has a visual problem. There is absolutely no use going to his back, okay, in my point of view. So, the information system. So now we have a second system. This is like the second issue. The second issue is all these systems require energy. So the muscle requires energy. The spinal cord needs energy. The brainstem needs energy. The brain needs energy. Okay, so all the time when it's doing work, when I'm moving my hand, my muscle in the arm needs to be supplied with oxygen and everything else the muscle needs. Okay. At the same time I do this, the part of my spinal cord responsible for firing also needs more blood. So there's more blood supply. So if you look at the spinal cord, there's a whole bunch of blood vessels in the spinal cord. So that's also active. Then the next thing is my cortex. So it's probably my motor cortex doing this right now. So on this side, so my motor cortex on this side is now being active. That's what we measure when we look at MRIs. MRIs are more blood flow in a particular part of the brain. So we're looking at blood flow. We're not looking at electric activity when we look at MRIs or functional MRIs. So the blood flow gets more over here. So I have to make sure to move my hand to have information. So my brain has to be able to coordinate the movement. So like cerebellum, like fast movements, rapid alternating movements of my hand or of my arm. That's something I do with my cortex, but also with my cerebellum. That helps me to do that coordinated thing. So this is like the information system, and on the second system is the autonomic system, making sure there is supply. Everything I'm doing here with the camera, with the computer, will not work if there is no energy, if there is no electricity. So all the algorithms and the technology is nothing with energy. Same with the body. So this is always our kind of first approach, not when we go into fundamentals of neurofunctional integration, but once we get really into it, first thing we do is autonomic. So what does that look like? Okay, so let me just illustrate that here with one simple system. So here you have maybe the heart. Okay, so you have the heart, all right, and of course the heart has a blood supply to the brain, and to the brain this is not correct, of course, and it has a blood supply to the body. Okay, and with this blood supply runs another system. I'm going to draw this in blue, which is the autonomic system. So you have all these autonomic ganglion, paravertebral ganglia and prevertebral ganglia, all these things. Of course, they're coming from the spinal cords. You have the vagus nerve going to the heart, all these things. So here you have another nervous system, of course, going into the periphery to regulate blood flow, for example. So this needs to be considered. And here's what can be. So somebody comes in and says, I have a knee pain. And I ask him, well, what happened? Did something happen? Well, I only hit my head pretty badly, but I only hit my head. Otherwise, I didn't bend my knee or didn't twist my knee. Nothing of that happened. I only hit my head. Well, right there, I say, well, I probably gonna have to look at your head very closely. Okay, so blood flow to the brain area. And we know now in studies that even a minor hit to the head can cause prolonged blood flow restrictions or blood flow changes to brain areas. So we need to look at blood vessels, and we need to look at blood flow. We need to look at the autonomic system. So all of a sudden, coming from the knee, we're here looking for blood flow to the cortex, for blood flow to the cerebellum, for blood flow to the brainstem. And now we're looking at local issues, but of course we have to be able to find that problem, not only through asking the patient what's going on, but through testing. So this is what we do. This is what we assess with the system I developed over the past years. This is what we assess. So we don't just check connectivity between the body and the brain. We look for very specific problems in the regulation, maybe of the cortex, maybe of the motor cortex related, for example, to blood flow. Also the cranium, all you osteopaths out there know that craniosacral osteopathy, never really understood that. Of course, the mechanics and all that, well, the sutures and things like that. Now I know it's the house of the brain. So it helps to regulate blood flow. It helps to regulate lymphatic flow. So it's like the housekeeper and the protective system of the nervous system. And if you have a problem in your skull, this could cause a problem in your blood flow and in your lymphatic flow, causing a problem in your cortex, because that's connected through the nervous system, causing a problem in your signaling, causing a problem in your knee movement. Sound complicated? Yes, in the end, it's not uncomplicated. The body is a very complex system, okay? And there's very easy techniques that you can apply very easily. You can just learn this in a few days. But if you want to really get down into it and really help people who've had problems for a long time, you need to go into more detail. You need to look at autonomic systems, and then, of course, also proprioceptive and somatomotor systems. All this is, of course, included in this thing. So these are the basic two things. So it comes down to looking at the part that's not working correctly. Then looking into the connectivity to the central nervous system, and then check if there's a problem with the central nervous system. So I have a whole bunch of people coming in with peripheral problems, foot problems, knee problems, and it turns out they have a problem with the autonomic system, like in the spinal cord. So they might have had some kind of contusion to the spinal cord. It doesn't have to be something bad. It doesn't have to be the big car accident. It doesn't have to be something big. It could be that they just tripped and kind of stumbled and fell maybe on their behind and kind of compressed all the vertebrae and all the tissue there, and that can just leave a slight impairment in autonomic function around the spinal cord, causing then signaling problems. And those are maybe people that do not say, well, I get up and I can't walk. There may be people that say, well, I'm pretty fine walking like this and I have no restrictions moving my leg, but once I start really using my leg, like when I do sports, then there is a problem. So there's a subtle problem in signaling, and that becomes more obvious, of course, the more signaling you need. Okay, so these two things, these are the basic two things we worry about. And of course, movement, like let's just think about movement real quick. Movement is something very, very complex. So when we just walk, we move a couple of hundred muscles here, and these need to be moved in a coordinated way. So like when we look at movement, we usually look at movement patterns. So there is gait pattern, of course, this thing, there is breathing patterns, there is turning patterns. So the whole body, like when I turn my head, the whole body orients into that direction. My eyes are always moving first, then my head moves, and then my body moves. And when I just do what I'm doing right now, and I'm drawing, I'm looking what my hand is doing. So my hand is always following my head, or my head is following my hand or my eyes. So these things are interconnected. So there's a lot of issues going on about what we call movement patterns or movement reflexes. So couple of people most people still say, well, you have these early child or these reflexes in early life that go away. Well, that's absolutely not true. When I turn my head, all my musculature it gets ready to extend on one side and flex on the other side, because then I might move over to like this to walk towards the door. So this is all still there. It's just not like when I have an adult on my table and I turn the head to the right, he's not going to lie like this on the table and flex his arm and his leg on one side and stretch out or extend his arm and leg on the other side. So that's not happening, but you can test it. The muscle function is different from the right side to the left side. Okay, so movement patterns are very important things. So moving through all of the seminars we have is basically going into the basic connectivity situations, into all the autonomics, supplying the periphery, supplying the spinal cord, and supplying the brain. And of course, then we go into movement patterns and exteroception and things like that. And then that's the big third thing, mindset or mental systems, mindset. So mindset is a huge thing. This is like more like the what I want to say, not just the wire, but what's coming through the wire. So the mindset of somebody is a very important feature, and you can treat that. Okay, so mindset can be treated in terms of, well, is my system to create mindset working correctly? Like, is my system to move my hand working correctly? If I have a certain idea, this might be dysfunctional in terms of, I always say, brain mechanics or brain electronics. Okay, so first thing we always do when we talk about mental systems, we test for mental function. We test the system to see, not in terms of doing tests like you do at a psychologist, like saying, well, what's your depression score or your fear score, things like that. It's putting things into action in the brain in terms of visualization and mental system. But then also, of course, then we go down into content and check, is that mindset really helpful? So if I have a mindset that is not helpful, I might not be able to do what I do. So here's an example. I had a patient, he had a cruciate ligament torn on his, I think it was his left knee, and it was torn for the second time. So he was playing he was doing quite a lot of sports, playing soccer. So he came into my practice, and kind of like one of the first things he said is, well, I don't know if my knee's gonna hold. Well, how do I want to move if I think my knee is not going to hold? Okay, how do you want to do that? And that's what I explained to him. Say, well, I can't treat your knee if you think it's not going to hold. Okay, so if you jump and you think it's going to break apart, well, that's the wrong mindset, because you're always going to be too careful. You're always going to impair your movement. You're always going to impair your coordination. So mindset is what's going on in the head. So this is a very important aspect of my everyday treatment. It's not like I'm only doing that if somebody says, well, I have fears and depression and things like that, and I have problems with my life. I check mindset all the time, because people come in with more or less conscious mindsets about what their body, and they think it doesn't matter. Man thought, well, he thought he was thinking correctly in terms of that's what he felt. But I explained to him, well, no. And we did the test, which was interesting. Then I let him jump, like a one-legged jump. I'd let him do that with his normal mindset. Oh, I don't know if it's going to hold or if it's going to break apart. And I told him, now explicitly think about this is really all okay. So it was operated. There was an MRI. It's all good. It's all fixed. It's all strong. Everything is there that you need. Just jump now. And he jumped, and right away jumped like 50 centimeters further, just by changing the mindset. I had people by changing their mindset that decreased pain by 80% right there, just changing the mindset with a decrease of pain. So that's also, of course, in my view, functional neurology. Okay, so it's not only about getting the wires back on track, it's also about getting the brain back on track, the attitude or the mindset toward what's going on with health or not health. Okay, so those are the big three: the wires transporting information from and to the body, the wires supplying the system with what they need. Oxygen, of course, there's also lymphatics and things like that. Also, there's content, of course, in the blood. So we eat stuff, we digest it, we put it in the blood, and we bring it to where it belongs, or through the lungs. And then we have the mindset of the brain. So that's the big three, and that's what we talk about when we talk about all our basic training. So what I'm going to do now, and let me just check the clock. Well, perfect. So now half an hour is past. I just explained some basics. So now you have the opportunity to ask me some questions if you want to. And I'm going to see that everything is online here. I'm going to see if somebody else wants to join the discussion, because I would like to hear what you think, where you come from, not in the geographic sense, but where you come from, like in a medical sense. So you can talk to me if you want to. So is there anybody who wants to ask me a question at this point? So, or comment on something, maybe saying, well, that's a whole bunch of I don't know what. So what I want to make sure, and this is what I might want to say at this point here, what I want to make sure, or what was a really important thing to me, is when I learned this, I had a whole bunch of like gaps, knowledge gaps, of course, explanatory gaps. I was lacking a lot of explanation. Why was this happening? Why was that happening? And I started reading a whole bunch of books, anatomy, physiology, psychology, emotion, physiology, biochemistry, all these things, to really get a fundamental understanding. And this is what is important to me, that it's really based in physiology and anatomy. What we do not have is any proof how this works or how effective this is. We don't have that. So this is not evidence-based, it's science-based. That's what we say. And that's really important to me, to have a very solid background on the anatomy, on the physiology, and really go through treating the patient with that detail. So anybody who wants to talk to me here at this point, and I'm just going to step over to here and make sure that my speaker is on. Let's see, speaker is on. Microphone, yeah, so speaker is on. So if you want to talk to me, you can. If you do not want to talk to me, that's also fine. Then I'll just keep talking, and I'll bring my son in, and we'll just do some practical things, okay? So basic idea is clear, I guess. And Maxi, is Maxi here? Maxi's here, okay. So here comes my son, Maxi. And we have, I'm just going to show how this works. So just get an idea of how to assess. So what I'm not going to show now is how to ask questions, of course, in terms of how are you doing. So that's, of course, what you do in your practice. What I'm also not going to show too much, or maybe a little bit, we'll see how this develops, is about a neurological assessment. So we do walking, we do stability, standing, we do one-legged stand for vestibular issues and stuff like that. We do coordinated movements. We do a lot of basic neurological testing also, just as a foundation, but this is not how we assess the system in terms of, okay, there's a lack of coordination in his left hand, so it's a cerebellar problem, and now we're just going to find out how we can treat the cerebellum. This is just to gather information and then go into the testing. And what we do through the testing is basically a lot through touching, but also with other stimuli. We work to activate certain pathways to the brain. So I'm not aware of that my son has been hurting anywhere, although he's playing some soccer and getting some hits here and there. So we're just gonna kind of walk you through this theoretically, and just so you know what's going on. So one thing that I learned is how to access the brain indirectly, so not through a direct function, because some areas you can't access through a direct function. So you have to kind of access this indirectly, and we do that a lot through touch. So of course, there's a lot of assumption in this, but when you test, and that's what we do always when we go into more detail, we test like if this part of the brain is a problem, then this or this function should be problematic, and then we can test that and correlate that. Like if we think the pons is a problem, breathing patterns could be a problem. Facial issues could be a problem, like jaw, clenching the jaw, because that's where the motor system is for the jaw. The facial nerve is located in the pons, or the nuclei are located in the pons, so contracting or activating the face could be a problem, and you can test that, and that correlates quite well. So I'm always astonished again how well my teacher did, like figuring out these contacts. So a very basic test, of course, is muscle function. That's what we use a lot. Not only, but muscle function is very useful in assessing and reassessing, like taking the basic assessment of the body function and see how that changes. So that's what we want to use. Okay, so here we have just muscle function. This is normal. A lot of people jump right to, oh, this is kinesiology. Well, I have no training in kinesiology, and muscle function testing is just part of neurology. So I'm testing the muscle to see if it facilitates, okay? The second thing I can look is to see if the muscle inhibits, so that's also a muscle function. So we divide into 3 types of muscle function: facilitation, inhibition, and movement patterns, okay? So let's see if it inhibits. We can just inhibit the muscle by going on the spindle, see if the muscle inhibits, and usually the muscle gets weaker. That's a normal reaction. That's like a physiological reaction. So now I know he can facilitate. He can access his muscle and make it strong. I can inhibit his muscle, so his part, and this is very often associated with brainstem or cerebellum. So this part of the nerve pathway also works. So if he would not inhibit, that already would be a problem. Okay. So next thing would be like something like movement pattern. So let me just show you a movement pattern. Okay. So hold your arm like this, please, and then just push outward. Okay. Push outward. Okay. So what you see right there, he's looking into that direction because that's normal. Kind of look what you're doing here. Okay. So that way he also facilitates that because he's already turning his head toward the outside. So let's see what happens when he turns his head away. Okay. So I want him to move his arm outward, and he's looking the other way. So what that does, it inhibits the muscle. Okay. That's normal. That's a normal function. So those are movement patterns. Okay. So he wants to move the arm out. His head is going this way. What his hand wants to do is his hand wants to go to where he's looking. Okay, that's the normal reaction. So those are the three basic things, and you cannot just test for muscle strength. Okay, you always have to test for inhibition. What I find is that inhibitory problems are much more common than facilitatory problems. I don't know if you can say it that way. So there's a lot more often, in my experience, a problem in the muscle inhibition. And usually that matches with what you experience when you're like touching. It's like, oh, the muscle is tight, it's not letting go, the movement is restricted, the range of motion is restricted. So that goes very well together with the idea that the muscle is shortened. Well, yeah, you have to stretch your muscle. That's like an idea where I say, well, I don't believe the muscle just shortens from sitting or something. If somebody's lying in bed for 6 weeks because he's very sick and the muscle shortens, yes, but somebody just working every day and maybe sitting at his desk, he's not going to have shortened muscles. Okay, maybe he's not that agile moving, that coordinated, but shortening muscles. I don't believe in that because I see it all the time. When I make the muscle go into inhibition, into physiological inhibition, or facilitate that to go into inhibition, then the range of motion improves usually right away. Okay, so this is just basic testing. This is basic assessment. He might come in and say, I have a shoulder problem, and he might say, well, it's shoulder problems when I rotate, and then I can check muscle function of the different muscles. I can check the inhibition, and then I can check for the movement patterns to see if there is a coordinated movement pattern going on or not. Okay, so now he might say that he has a shoulder problem. Okay, so let's just assume he has a shoulder problem. And I tested all his muscle, and all his muscle seemed to be working fine. Okay, so all his muscles facilitate, all his muscles can inhibit when I touch the muscle spindles or when I activate the muscle spindles, and there's no real movement pattern disorder. So that already would bring me to a point where I would say it's probably autonomic. It's probably an autonomic problem, maybe lymphatic or maybe vascular. Okay, so then what I would do is I would activate motor systems by testing and activate sensory systems by touching. Okay, so then you could go and like kind of rub over the shoulder and see if anything is happening there. So if nothing is happening there, then you start connecting the shoulder to different parts of the nervous system. So let me just turn you around. So the next part where the shoulder would be connected to is in terms of motor function, is the spinal cord right here, the cervical spine. If you're looking more for autonomics, it's the thoracic spine, the upper thoracics. Okay, so then you can just test the motor function by touching here. So this would affect the motor function, or this would affect the sensory function, and do that. Okay, so basically what you're doing, you're kind of interfering with the sensors here, with the sensors here, and then with the sensors on the head. And these sensors on the head, because we cannot go into the head, well, with function, yes, but not with touching. So there's a lot of outside contexts that are very well suited to get access to the central nervous system. So next step would be to go and test to the brain stem. So going here under the jaw, right here. So I'm just under the jaw here, correlates very well with what we believe functions of the medulla oblongata. So very basic functions. There's movement function there, but there's also, of course, autonomic function. So then you go again and you test by touching sensory input, and then you add another sensory input, and then you test again. Okay, so next step could be going to the cerebellum. So now I'm going to the back of his head, central part of cerebellum, more of an autonomic part of the cerebellum, or most people usually don't know that, and the lateral part of the cerebellum, more like a coordinative part of the cerebellum. Okay, so I'm kind of simplifying that right now. So then you touch the shoulder and you kind of see what's going on between the shoulder and the cerebellum. And then you touch the shoulder and you kind of see what's going on with the shoulder and the pons. So this is a contact in the back of the head. And you touch the shoulder and you see what's going on with mesencephalon, which we use. This is a contact on C1, on the laterals of C1, because mesencephalon has a lot to do with eye-head coordination. So you can use this contact for mesencephalon level. Touch here, and test to see if something going on. So he doesn't have a problem, so there's no disruption in that system. Okay, so functional connectivity is basically what's behind this, is tested by, in my understanding, interference with that wire. Okay, so I'm kind of stressing the system. I'm putting information into it at different points to see how he reacts, and this is what we believe, and we can't say this, we know this because we have no evidence for this. Okay, this is what we believe shows a disruptive pattern, a bad connectivity between like the shoulder and maybe the cerebellum. Okay, so what would happen? What would happen if there would be a disrupted pattern? Let's go back to the spinal cord, because I said, well, there's no movement pattern disorder. He kind of facilitates normally. He kind of inhibits normally. So it's probably more autonomic. So the autonomics of the shoulder and the arm, they're up here in the upper thoracic. So this could look like I'm touching the shoulder. And usually you should touch the shoulder where it's hurting, okay? So if you're saying, well, the shoulder is hurting in the back, you touch more in the back. If it's in the front, you touch more the front. So you touch the shoulder, you touch the spine, and you test. So then it would go weak. And we're just going to imitate that, okay? We're just going to pretend that he has a problem. So this is what it would look like, and the muscle would go weak. The muscle would weaken. The reaction would be altered, okay? So there would be a difference. Where I touch here and touch there, nothing is happening, and then all of a sudden I touch this certain part, the certain connection between the shoulder and the autonomics, and then the muscle will weaken, which will show that there is a dysfunctional pattern there. Okay, so right there, this is the simplest way, and this is what we usually teach in our first fundamentals. Right there, you can go into for integration. So that's how I treated for 10 years. Just find the disconnectivity and put the connectivity back by tapping on the head. This was something when I first learned that, when I first did my seminar in 2003 with my teacher, Dr. Phillips, I kind of said, well, yeah, okay, right. So in medical school, I was taught, you know, you have all this medication and you have all these surgery things going on, and now he just says, well, all you have to do is tap on the head, all right? But I felt immediate changes in my body, in the function. So I said, well, of course, I don't understand this, but it is working somehow, okay? So what does that look like? Usually the activation for all circuits, and that's kind of the weird thing about this, the activation for all circuits can happen through this part of the skull, okay? So you're basically just activating the skull, because that's what you can activate. You can activate the skin and the skull. And you do that while you activate the shoulder and the spinal cord. So it's shoulder, spinal cord, skull. So you can do it like this. You can go back and forth like right here, or you can just touch, 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 touch. Or he can hold his shoulder. You can go on his shoulder, and I go on here and I do this, okay? So it's activating things at the same time, and this is important. I cannot activate the shoulder, then activate the spinal cord like 5 minutes later, and then activate the head. I have to do that in the same time. So this brings me back to a technological comparison, which is synchronicity. So I talked to my guy at the telecommunication company because my internet was going on and off. And then he tested it, he measured it, and he said, well, it's only synchronized 40%. Okay, and then he resynchronized and then it worked again. So I thought, oh, that's interesting. I think we're doing the same thing because technically you can measure synchronicity in the nervous system. Okay, so like heart coherence patterns, corticomotor coherence patterns for the musculature, those are things that can be measured, and they show that the cells need to synchronize. Okay, and synchronization is something going on at the same time. So this is, to me, one of the key things to understand is, yes, there's a whole bunch of holistic, integrated things, considerations where you say, well, you have to look at the foot if there's a back problem, or you have to look at the back when there's a foot problem, and then the back is treated, or the foot is treated, or the head is treated like we did in osteopathy. Of course, these things do work to a certain degree, but here it's really about synchronicity. So I'm treating a wire, so I have to go from here to here to here. That's what I have to do. This is what this is basically all about. Okay, so it's a activation of the system to connect parts of the body with parts of the nervous system. Of course, you also want to connect parts of the nervous system with other parts of the nervous system, or central nervous system, I want to say. Okay, so this is like the very basic thing, and what you can do now in principle, if you understand, and I want to just give all the other people joining in a little bit later, and you will be able to watch this on our online academy if you want to, and we're probably also going to put it on YouTube. You can watch this and see what we did before this. Okay, so I'm just going to give you the opportunity to join us in the discussion here. All right, so very basic. Okay, so you have context for the brain stem. All right, so this is a contact where you can access lower brain stem, which means medulla oblongata. Okay, this is a contact back here, so you can also go like this to access the lower parts, or the parts of the cerebellum. Okay, so holding your hand right here, and then you can access, and this is kind of weird that the contact is up there, but it correlates with functions of the pons. When you go a little higher, and just in the back here, you can access function of the pons through touching the back of the head. Kind of weird, isn't it? And then you can go on C1, the transverse process in C1, which will give you a contact or a access to mesencephalic functions. Okay, so basically you can use these tomorrow in your practice. If you already know how to test muscle function, you can just use muscle function as a tool, but now you can look, if a patient comes in and says, well, I have a knee problem or a back problem, just test the back with the medulla, for example, or the back with the cerebellum, because they are connected, of course. And if there is a dysfunction in the muscle that hasn't been there before, you can just go ahead and repeat the contacts, repeat the touching, and go up to the skull and just integrate it. And you might find that, just a little intervention already changed a bit of the movement pattern, maybe a bit of the symptoms. Sometimes it could create a big change. It depends on what else is going on there. So you could be lucky and like integrate maybe 1 or 2 pathways with the brainstem and have 50% in pain reduction. That can happen. You could also have no reduction in pain because there's a whole bunch of other things going on. You could have, it's possible, by integrating 2 wires, you could have full pain relief. Possible. Okay. You don't need to manipulate, you don't need to stretch, you don't need to do myofascial release, you don't need to do training. You just have to unplug and replug the wire, because that's how I fixed my printer. So this is how you can also fix body function. Okay, so what we can also do is we can have an extended way, and this is usually how I treat. The extended way would be if we go back to his assumed problem of his shoulder, connectivity to his spinal cord, lower upper thoracics in terms of autonomics, and this gives an inhibition to the muscle. So when he does this, and I touch here, and I touch here, and then I test the motor system, okay, this might be weak, of course. This is what we want to have, might be weak. And then what I would do, and this is just pretended that it's weak, so what I do is then look for another contact somewhere in the body. Very often it would be located in the central nervous system. Quite often it could also be located in the peripheral autonomic nervous system or in the peripheral nervous system. So I look for a third contact to facilitate the muscles, so the muscles going back into strength. And this is the idea of, if there's a mistake in the system, I need some activation. Okay, I can get the general activation here, that will also work. And I can give a specific activation, like taking another part of the brain, like a cortical part of the brain, to activate that, to put the system back into normal function. Okay, so what is the difference here? Well, it's more complex in the treatment, so you can get more complex pathways integrated. The difference for the patient is, if you treat just the two contacts that cause dysfunction, you might get reactions like, I didn't feel so well a few days after this the treatment. Okay, so the pain was even maybe a little stronger and started working. So reactions to the treatments are occurring more often when you go just integrating the dysfunction. If you go the further step, and of course you need to know where to touch and what to do and how to test this, then you can get a more complex treatment. You need less treatments or less integrations, and you can also have less reaction to the treatment, because it's like giving the body already a solution. Okay, so this is like what we call the advanced, or the advanced integration process. Okay, so let me just do something here. Different type of testing, just to show that also. Okay, so what you can also do is, instead of just touching, which is in a way a specific sensory modality, touch, okay, you can alter it and like use vibration. Okay, so you can just put in a proprioceptive stimulus to activate the body. We're just going to go through the spine, because quite often somebody does some sports. Okay, we're just going to go down here and see if it has any weakness when we activate a little differently. So if we go right here, no, that's all good, all good, all good. Okay, so yeah, stay right there. Okay, see if we can find something. Okay, we don't want to pretend anything. So right here, okay, so let me do that again. So if I go into his upper thoracics right here and I use his left arm, he inhibits. Okay, so I'm going to go down here. There's nothing going on right here. So I go up here, same thing again. Okay, just turn around so we can see it from this side. Okay, so doing nothing. We have to wait a second. Sensory discharge. No. Okay, so I'm up here, upper thoracic, going down a little lower, and then it goes weak. So it happens again and again. So something is disrupting his muscle function over here on the side. So now I'm just going to go back to touching. Okay, so I'm just going to touch there. There's nothing happening really right there. No, it's back to strength. Okay, so sometimes you want to use a very specific stimulus, and what you can do here, you cannot integrate this. This will not work. Sometimes it works, but it will not work. So I'm going to try to show you how like the advanced integration process would look like with testing a specific function. And this, of course, can be applied to anything. Specific eye movements, specific vestibular function, specific sensory function about hearing, smelling, feeling, warm, cold, all these things can be tested, okay? So, but what you need to do after that, you cannot just test the sensory modality and then integrate that. Sometimes it will work, sometimes it will not work. But what you can do is you can access the system through going here and then looking where does it facilitate again, okay? And quite a lot of times it will facilitate through the medulla. Why? Because all the wires are going through the medulla. Not all the wires are interacting with the medulla, but a lot of wires are interacting with the medulla. And this is a proprioceptive stimulus. So where does proprioception go? It doesn't really like switch over in the spinal cord. It goes directly to the medulla. Like this could be going to the gracilis, or maybe we don't know right now because we're in the back, we're not in the periphery. Could also be the cuneate nucleus where it's going to. Okay, and where do they sit? They sit in the medulla. So I'm activating the medulla. So let's just go back and say, well, I'm claiming this is the medulla. Okay, this is what I'm claiming. All right. It could be anything else. Okay, so let's think about a function of the medulla. So thinking about a function of the medulla, it's always easy to think about cranial nerve. So we have cranial nerve 12, 11, 10, 9, all sitting in the lower brainstem and the medulla. So let's just activate the medulla through maybe cranial nerve 10. So how can I do that? By activating the voice. Humming, for example, is something that activates the cranial nerve 10. Vagus nerve is responsible for speaking, for the voice. So let him hum, okay? So I'm going back here. Don't hum yet, all right? Don't hum yet. Okay, so I go back here. It's still going weak, okay? So I can do this all day long. It will still go weak. So let him, I'm not going to touch here now. I'm going to let him hum, okay? So just go and hold very strong. Okay, so this will work quite often, not all the time. It's not always like cranial nerve 10. It could also be cranial nerve 11, so I could let him shrug his shoulders. I could do that. So I can change a contact with a function that is associated with what we believe is behind this, and this is how we know, or how we strengthen our belief, and okay, this correlates with function in the medulla. Okay, so this is how we learn about contacts correlating to brain areas, correlating to brain area functions. Okay, and now I can integrate this. This is exactly what it would look like, and this is why it's called neuro-functional integration, not just neurological integration, where we just touch and touch and touch. So now I go back here, he hums, all right? And then I can do this, or I can just leave this away. He's humming, so I don't need that, okay? I could do this, but I don't really need that. So I can alter the contact back here a little bit. So this is the integration process, okay? Good. That's all it is, all right? That's the treatment, okay? Very easy on everybody. Okay, let's go back to see what the function is. So let's test his arm. His arm is doing fine. Let's go back to the spine, apply some vibration, and his arm is still fine, okay? So it's just about information, okay? So that's just about signaling, all right? That's what we have to be aware of. Of course, if there is a structural problem, I might have to access the structural issue by going there and working with it, stretching it, doing whatever, or even have surgery with it. But if it's a signal problem, it doesn't really need a massage or a manipulation. It just needs a altered signal, and that's what we're doing. And I have a whole bunch of patients coming in with a whole bunch of things that are like old and really old and really, really old, like, oh yeah, I had an accident 20 years ago, and since then I've always had hip problems, and I can resolve it by doing this and this and that, but it always comes back. Well, let's have a look at it, and it's no wonder that it's not working, because it might be proprioceptive systems not working, interoceptive systems not working, somatomotor systems not working, and so on. The movement patterns are not working, the coordination are not working. So, well, how will the hip function, and what will a treatment, a local treatment, do for all these very specific wires that you have in your central nervous that are for very specific functions? So you have to reset those, of course.